Can you see my slides? So what holds it all together is that I'm an addiction psychiatrist focusing generally on addiction and concurrent disorder, but I do obviously have an interest in the new and developing areas. I will talk about psychedelic medicine as we are starting to run studies here on psychedelic medicine. We'll talk about the background and the neuropharmacology, the current status of the treatment, which is fairly new, and then end up with discussion and summary. First, the substances. The substance which probably all of you know is LSD, which was developed by Dr. Albert Hofmann in Basel in, I think, in the 1930s. All the psychedelic substances have been Schedule 1 so far, and that happened about 50 to 60 years ago and stopped the psychedelic research at that time point. And obviously, currently, we are experiencing a renaissance of this. I will talk about the different substances a little bit, mainly with a focus on the question regarding therapy. And LSD is quite bioavailable, quite fast. When you look at the duration, it says 8 to 12 hours. Generally, it's intoxicating, or the psychedelic effect lasts for 8 hours, which is clearly a long time. Let me see it. Okay. The substance which currently is the substance which gets most of the attention is psilocybin, or magic mushroom is the plant where psilocybin is mainly kind of like produced from. Again, Schedule 1. The time of the psychedelic experience or the intoxication is somewhat shorter. It's about more like 6 hours. It says here 4 to 12 hours, but with this more standardized substance, it's about 6 hours lasting. So similar to LSD, a little bit shorter. And then the last substance I want to mention is the DMT, which currently is not researched very much, but I mention it simply because it is currently being discussed, and the duration of action is way shorter than the duration of action for LSD and psilocybin. As I mentioned, there was a lot of research on LSD in the 1970s or until the 1970s, and with the Scheduling 1, it became much more difficult or impossible to do any research. And there has been ongoing research, but only in the last 10 to 20 years have we seen a surge again of psychedelic research. What you can see here also is that there is some LSD research, but when I'm not talking about MDMA, by the way, which is also mentioned here, which has a little bit of different mechanism, which sometimes is put into the same pot also with ketamine. We'll talk about that maybe a little bit later, but I will focus on psilocybin and LSD. And what you can see is really the main number of studies is on psilocybin. And the simple factor is the duration, because when you do treatment with these substances, you need to have a psychotherapist with them for the duration of the intoxication time. And what it means is, sorry, with LSD, you need 10 psychotherapists or a nurse for 10 hours supervising the patient or working with the patient. And FDA and Health Canada, the agencies which are responsible for getting the substances marketing or making it possible to use it as medication, have mandated actually for 2 therapists to be present during the sessions. That has been the case because there have been in the initial phase of the study incidents where the therapist did inappropriately cross professional boundaries, and the patient during that time are very vulnerable. So currently the mandate is that you have to have 2 nurses or counselors with the patient throughout the time of the intoxication. This is again the hours. What you can see, DTMT is much shorter. There is currently studies going on with DMT, for example, in the Netherlands, Wim van der Brink. There is also another way of shortening the length of the current psychedelic experience. It is not clear, and it's probably not necessary to have like the long-term psychedelic experience to have the clinical effect. And so shortening it would be helpful. The second way of shortening this would be through using an antagonist, and that is a study which came out this year, where Matthias Lichty, who was one of the biggest researchers in this area, reversed the acute response to LSD using ketanserin, which is an antagonist on the serotonin 2A receptor. When we look at the psychedelic effect, that is the effect which seems to be necessarily to have the treatment outcome. The subjective experience can be measured in the altered state of conscious rating scale, which was developed in Switzerland. And what you can see here is actually, if you look at psilocybin has the strongest effect on complex imagery and elementary imagery, so it's hallucinations. When you look at ketamine, it has, so to say, the peak in disembodiment, a more physical experience. Again, ketamine is also much shorter in its action. And with MDMA, it's more the spiritual experience, the blissful state. So while there is overlap in the experience, there is some differences in the different psychedelic experience. Ketamine obviously has been improved, and it was ketamine's success in treating depression which initiated the whole psychedelic renaissance. This is the full assessment of the altered state of consciousness, which is a fairly long questionnaire and is currently being reinvestigated because simply trying to make it a little bit more shorter. One question which has come up is, when we do psychedelic treatment, is it the subjective effects or is it some other effects? And are these subjective effects actually only epiphenomenon? So do people really need to have the subjective effects? And currently it seems to be the case that it is necessary to have the subjective effects to be effective. There is also this approach where people do microdosing, meaning they give small doses over long effects where there is no kind of immediate subjective experience similar to the psychedelic effects. And the data indicate that this approach might not be as effective. If anything, there is a high correlation with expectancy, which actually indicates that it might be placebo effect. So what is happening? I mean, this is a very disruptive approach. It's very different from the medication in psychiatry, which you take over long times, often lifelong, that you have an interventions which is, if anything, closer to ECT, where you just do have 1 session or 2 sessions and seem to have an impact which is long-lasting. The length of the effect has not been studied at the moment, but it's definitely clear that it has effects lasting for a half a year to a year. And the explanation why this is the case is currently not really clear. The hypotheses are that there's increased cognitive and psychological flexibility. So there's a, so to say, shake up and the new openness towards changing. There is an increase in psychological insight, and there's a heightened emotional acceptance. So why is this happening? There is pharmacological explanations, but there are also psychological explanations, and both are actually, if anything, happening in parallel. I talked a little bit about the psychological effects, but we can look at the brain too. And what we have is generally when people look at the brain, there are two levels. One is the more molecular level, which is the pharmacological level, so to say. And the second is more the network and circuit level, which is more the level characterized by neuroimaging. Let me first look at the molecular level. All psychedelics increase the serotonergic 2A receptor stimulation, and I will talk a little bit about that. It increases indirectly the cortical glutamatergic transmission, and that means it increases neuroplasticity, which is actually something which is also discussed with ECT. Then finally, there's a very separate effect, which is decreased inflammation. So psilocybin has been studied in humans a lot, but also in animals. And this is animal studies showing that psilocybin does increase the spine density after the administration of psilocybin. It ameliorates stress-related behavioral deficits, so it has a positive impact on learned helplessness, and it has an impact on the neurotransmission. The person who has done most studies on the mechanism of psilocybin is Xaver Vollenweider from Switzerland. He has been studying it for 30 years. He mainly has not looked at the treatment outcome, but has more looked at the mechanism. And he came up with this picture showing that psilocybin is metabolized to psilocin, and that there's agreement, increases the activity at the serotonin 2A receptors, but has also impact on other receptors. LSD has additional impact on dopaminergic receptors. And these serotonergic activation has indirect activation to GABA, dopamine, and what is probably very important is the glutamine release. He kind of come up with a quite comprehensive picture of how this is all related. I will skip that. But since we are as psychiatrists quite aware of the serotonergic mechanism underlying the treatment with SSRIs, the question is, so if that is that approach is impacting on the serotonergic system, what's the difference? The SSRIs are actually more active on the 1A receptor, which is more in the limbic system. So the explanation given here by the English group, which has done a lot of work on psilocybin, is that you have a reduction by the SSRI on the limbic responsivity. So you have a reduction in the stress experience, and this indirectly increases resilience, and they enhance the emotions, while the 2A receptors are more located in the cortex, and psychedelics increase the serotonergic 2A receptor signaling. The cortical entropy is increased, which really means increasing chaos, which is then kind of translated into reduction of the rigid thinking. That's at least the hypothesis, And so to say, this reduction in the rigid thinking increases the capacity to reassess environmental experiences and reassess also the personal experience, the emotional experience. So it is kind of like, again, the idea that there is increased flexibility and increased possibilities for modulation and change. And this is also kind of the idea that when you have psychedelic medication, you combine it with psychotherapy because you can utilize this increasing flexibility to change the outlook and to change the interaction with the environment, but also with personal experience. In imaging studies, there has been data produced showing that the brain seems to decrease modularity. That means an increase in the functional connectivity and an increase in the overall entropy. So what it does mean is there is an increased connectivity in the sensory cortex, but there is a decreased connectivity in the association cortex. So overall, there's a little bit of changes in the different modules of the brain. What Madsen was writing is the serotonin 2A receptor critically mediates effects on neural processes that manifest reduced functional connectivity within discrete brain networks. So it's reduced integrity and reduced segregation. So there is a more talk between, not within, specific regions of the brain. There has been demonstration that the receptor activation is associated or is running in parallel with the psychological experience, such as self-dissolution. And that also been shown that the changes in the connectivity are related to the outcome. So we have the changes in the brain being related to the experience per se, but also being related to the outcome. Speaking again for the need to have this psychedelic experience to have the positive outcome. Vollenweider again summarizes that there are decreased integrative processes and increased sensory processes. So there is the capacity that, for change is increased. Currently, the big issue with the studies is that we have very little solid evidence. We have a lot of studies which have not really large group sizes. Here I have been focusing on substance use disorders. There has been studies on alcohol use disorders, and what you can see is that the sample sizes are fairly small. For most studies, 10 persons here, 15 persons. 95 subjects is one of the largest studies, if not the largest study so far. Then when you look at major depressive disorder, this is the largest is with 56, are still fairly small studies. So currently the results of the studies are very impressive and very convincing. But one issue has been that most of the studies are really at the level of phase 2 studies, meaning studies which indicate safety of the application and indicate a possible positive outcome, but no definitive studies, really. These are kind of like ongoing studies at the moment. And when you can see the sample size go up a little bit, we are part of these alcohol studies, which is being conducted in Canada and in Finland. And The sample sizes go up a little bit, but overall still kind of like limited studies. We see also, which I did not discuss before in the slide, more RCTs, less open label studies, but there's also some issues with RCTs. Let me see. Oh. Okay, the issue with RCTs is that really it's very hard to have placebo controlled, because you need to have the psychedelic experience, and the patients do know if they are on the active medication or on the placebo. And I will talk about that a little bit more. When you see also one other aspect on the follow-ups, the follow-ups are often fairly short, 12 weeks, 8 weeks. So there's still a lot to do in that area to get the data we need to talk about a established study. Some clinical aspects of psychedelic approach. Currently, it's a highly selected population which is being tested. We, I think, have so far around 5 patients, and we have screened 200. There is a highly a good preparation set and setting obviously is important. So the patient need to be well prepared for the psychedelic experience. The setting is, that is the setting. It looks even a little bit nicer by now, but that is when we started. This is the setup, the room. Then I already discussed of the issue of professionalism, that the participants, the patients, are very vulnerable during the psychedelic state, and that is a concern, specifically when these approaches become more standard. It currently is very costly. We have to have a physician for 4 hours and 2 professionals for 8 hours for each session, which is considered quite high cost. And while we so far have not been experiencing or seeing a lot of side effects, we have to say that we are also treating a very selected population. This is again the comparison of the different studies. This is a non-hallucinogenic study, and when you can see included in the studies, in the recent published studies, is like 5% or 3%. So it's a highly screened population. The main issue screened for is history of psychosis. So we exclude, for example, anybody who has a relative, close relative with psychosis, a history of any form of psychosis, a history of any forms of suicidality. I already talked also that it's very difficult to develop a placebo. People have tried other substances, but the problem is that if you're experience a psilocybin intoxication.
Christian, you sure I can't, Christian, just to stop. Can you make sure that we can see your screen and the video? So I don't know this. It's black now with me.
It's black. Okay.
Yeah. All right, that's better.
Can you see it again?
Yeah. I think it seems you lost a little bit of. That's darker now.
Can you see it now?
No, it's darker now. You had it lighter in a bit.
Better?
Yeah, it's better, getting better. So I think possibly your screen is going a bit low. Yeah, that's fine.
Okay, sorry about that. So I don't know if it's that slide, because I just added that slide this morning. You can see that I saw movements and things that weren't actually movement, which is reported in nearly everybody who is on psilocybin, and practically nobody in red on placebo. And the one report which sticks out for placebos, I felt entirely normal. So this slide clearly shows that it's practically impossible to do a placebo-controlled trial. We are trying, and we are seeing now if we give some psilocybin that the expectancy is higher, but this is one of the issues still in the field. Others have tried with benzodiazepines, but people know that this is not the same if they're a little bit sedated or if they have a psychedelic experience. One thing to try
Sorry,
to
I have to moan again. Sorry, that's better now.
Okay. So, I don't know. I don't see any change on my side, so that makes it hard for me to adapt. Sorry. Let me know if there's a problem again.
Okay. No problem.
So one thing is we are running an expectancy assessment with the study, so that we can see if there's a correlation between expectancy and outcome, which would be an indicator that we have a placebo effect. The big issue is also that obviously with psilocybin study, we will have a lot of people who have high expectancy on that, so that within the study field, we have to see if the effect sizes we are seeing currently will be maintained once we deal with, so to say, a population which is less well selected. There is also some approach now trying to understand if certain personality traits have an impact on the outcome, but this is just being started. When we look at overall, and I'm summarizing the results, psychedelic treatment is associated with enormous expectations. That's one of the issues I'm seeing at the moment, is that the participant in the studies often have come with high expectations, and we have the problem of blinding. So there is still this issue in the field that some of the effects might be really kind of like placebo effects. We have been seeing first promising studies. However, if you look at the overall situation, there is a lot of pilot studies and a lot of short studies. So there's the need for larger and more comprehensive studies. Interestingly enough, this approach is very transdiagnostic. So we are seeing this approach being conducted in very different fields of psychiatry, from OCD over major depressive disorder. I'm focusing on substance use disorder. So we are currently running a study on alcohol use disorder, but we are starting a study on opiate disorder, and we will next year start a study on stimulant use disorder. The psychedelic appears to have very few side effects. The main issue being that we see a small increase in the blood pressure. There have been reports on some people developing anxiety during the session. But overall, I think on average, when medication is available to support people, for example, with anxiety, like benzodiazepines, that has been used in less than 1% of the participants. There is also a big discussion about the psychotherapy going with the psychedelic approach, the integration psychotherapy, which tries to help people to understand the experience and translate it into the therapeutic outcome. And there is some standards being developed currently, but there obviously is not any consistency yet. Then if it is developed and if it is effective, it would be another, I would say, disruptive treatment, not very dissimilar to, for example, also TMS and ECT, changing the capacity to intervene acute or punctual without the patient needing to continue to take a medication over long term. I already indicated that one of the interesting aspects of these TMS and psychedelic is that it's very transdiagnostic, and it seems to have impact on more than one disorder. This is specifically important for somebody like me working in the field of concurrent disorder, where we are always looking for interventions which are kind of like reaching maybe a broader or more basic process so that we can have impact not only on one of the mental disorders, but maybe on more aspects of the mental disorders, which might be the course for concurrent or dual disorders. And that's it. Thank you very much. Sorry.
Right, Christian, thanks a lot. Thanks so much. Can I ask you, sorry, just to be visible here. Can I ask you, I tried my initial PhD thesis, I tried to do with Hans Leuner, who was psychobilin, and but the whole idea they had was doing some psychotherapy or psychoanalysis. So what are you guys doing then during the time when people are whatever, elated, psychotic, or
yes, that obviously when people are in the state, one of the main thing is to keep them from kind of like dealing with it, right? So that is, it's really kind of like the preparation phase where you kind of like discuss the experience, and then afterwards to try to integrate it. So we do kind of like have a focus on change, and we do actually combine this approach with very traditional motivational interviewing, which is important for substance use disorder, and some CBT approaches. So the idea is, again, to increase the openness and increase the capacity to discuss, have more insight, but also to have more kind of like a flexibility in capacity to change. So in the studies we're doing currently, we have we have 8 sessions, 8 psychotherapy sessions. We are conducting 2 before and then 6 after. So it is quite limited, actually. I know that other groups, like in Switzerland, like Zurino and others, they have way more psychotherapeutic interventions. But given these are research studies, and also given the North American context, the psychotherapy is actually pretty targeted.
All right. But you know, how, so would the psychotherapy be at the same time when you give the psychedelic treatment?
No. The counselors and the psychotherapists are with the patient during the time of the and they discuss with them during the time of the psychedelic experience, but the main work is really done before and afterwards.
All right, okay. So and you wouldn't, you know, so the idea of this Hans-Georg Leuner was more or less to do it at the same time.
The thing is that probably the level of psychedelic experience is important, right? They have substantial psychedelic experience, so it's not just a little bit a change. They sometimes really start kind of like yelling, rolling around. So it varies, the psychedelic experience, but it is not really kind of like during these specific phases that the psychotherapy is applied. It is there, for example, there is a discussion afterwards, what was the experience, you know, and where can you go with that? It is a lot about opening up and a lot about, so to say, having new possibilities and moving on. But that's not happening. It can happen during the session, but it's not like the session is supposed to be the main focus for that.
Right. Is there any other questions? I don't think so. I think some people are a bit knackered because they had now 7 hours of.
I know.
But so I think we just generated a little bit of a psychedelic experience. You know, having whatever lectures going